background. Okay, yeah. So it requires a little bit of clinical knowledge. So with me being in fourth year, I try to incorporate stuff that are relevant to you and that are, you know, not excessive. And I try to stick to the PowerPoint presentation as much as I can. If you have any questions, please write it in the comment in the chat box below. And if you have any questions later on after the lecture, then you can definitely email me. Okay, so these are the objectives of our session. Let's begin by discussing the definitions, and let's quickly go over some of the definitions before we jump on to the main topic. So loss of consciousness. So a loss of consciousness is a state in which there is loss of awareness, and it could be loss of awareness to oneself, to the surrounding of the patient, and it is the inability to respond to a stimuli, right? So it could be loss of sensory stimuli or auditory stimuli, and this could be in the case of syncope or seizures. Now, consciousness is preserved in dizziness, vertigo, and imbalance, right? So these states, the patient is awake, they're aware of their surroundings, they're aware of themselves, and they do respond to stimuli. Now, what is a nystagmus? Now, you must have heard this term a lot in the in pro and probably in clinical as well. So nystagmus is referring to the movement of your eye, okay? And it's this rhythmic side-to-side movement, and it's not necessarily just side to side. It could be up and down, it could be left to right. So, but the point is that it's a movement, a rhythmic movement of the eye, okay? Now, what is dizziness? So we tend to use the words dizziness and vertigo like interchangeably. Now, dizziness is basically, it's a disturbance in your spatial orientation, okay? But it does not give you a false sense of motion. So it's just a feeling, that's what it is. Whereas vertigo, it's the sense of something spinning or swaying, okay? You feel like there is this motion around you, which is not really the case in dizziness. Now, there are two types of vertigos. There could be internal, or it could be external, okay? But the point is that the patient or the person who's experiencing it is stable, they're stationary, but they feel like their surrounding is swaying, it's moving back and forth. And this is usually due to some vestibular dysfunction, so inner ear dysfunction. It could be any trigger in the central nervous system that could cause you to have vertigo. Now, gait imbalance. What does gait imbalance means? It means it's a way of walking, but when you're not really stable, okay? So it's this unsure feeling while you're walking, and it improves when the person sits down. Now, ataxia is the inability to not coordinate purposeful movements. So it's very different from gait imbalance. Gait imbalance is just like a feeling, whereas ataxia is when you have this unpurposeful feeling and you cannot coordinate your movements, okay? So now that we've discussed the certain definitions, now let's say that we have a patient who comes to us complaining of any of the following things that we just spoke about. So ideally, what should you do first? Whenever a patient comes to you complaining of a symptom, what do you do first? Now, I want you guys to please interact with me so I know that I'm making sense. You can say it in the chat. Guys, I'm waiting. Okay, all right. So Romberg test and checking the blood pressure, those are, yes, initial tests that you do. But whenever a patient comes to you, the first thing you do is that you take history of the patient, right? Any symptom that they mention, any symptom that they're talking about, first thing you do is you take a full history. Ask them, when did it start? What were you doing when it started? Does anything make it better? Anything worse? Is this the first time? You know, all the questions that we took in pro, you do that. And then you move on to, yes, someone said correctly, you check the blood pressure, you check their vitals, pulse, temperature, all these things. And then you do some bedside tests. Now, bedside tests were focused a lot in your presentation. And I know that this is a pro topic, but let's try to like simplify and make sense out of why you do the tests that were mentioned in your presentation. Okay, so let's first talk about the vestibular examination. So the vestibule is the inner ear, right? And so to examine that, there is a test that is done. It's called the horizontal passive rotation. Now, this test is done to differentiate between central versus peripheral vertigo. So vertigo that is caused because of some dysfunction in the central nervous system, or vertigo that is caused from the inner ear. So this test is used to differentiate between that. All right, so what do? You make the person sit down. There's actually this picture here. So basically you make the person sit down and you grab their head and you ask them to focus on a certain point, any point. Okay, look straight to your nose maybe, or look into your eyes, anything. And then you take their head and you tilt it. And you watch if their eyes move with the head tilt. Normally, ideally, their eyes should stay straight at the focus point. Their eyes should not move from the focus point. So, so it's basically you're taking the patient's head and you're thrusting it, okay? Now, what is corrective or catch-up saccade? So basically, this term was mentioned in your presentation, and I would like to elaborate on what this is. Basically, a corrective or catch-up saccade is when the eyes move in coordination to the head. Okay, so when this is there, this means that there is some deficit in the patient. There's something wrong. Normally, the eye should stay focused or fixed at a point in this kind of test. It should, when you ask the patient to look at my nose and not move your eyes while I turn your head, they shouldn't be able to do that. But if they move their head, it's called corrective or catch-up saccade. Okay. And where can we see this? We can see this in vestibular neuritis, in gentamicin autotoxicity. I'm pretty sure you guys took what gentamicin is. So, you know, one of the major side effects of gentamicin is autotoxicity. It could be idiopathic, it could be autoimmune, but it can be normally found in elderly patients. Okay. All right, so we actually do catch-up saccade if you think about it, like when we are reading a text, we're quickly skimming through a text, right? It's just our head is still, but our eyes are moving back and forth. This is a type of voluntary saccade, but here we're talking about corrective or catch-up saccade. Okay, now this is the picture that we already discussed. Now, another popular test. Yes, it's peripheral nystagmus. If it's positive, then it's definitely, it's a peripheral nystagmus. It's not central. Okay, so let's talk about now this, let's talk about the Snellen chart. So this chart, you probably would have seen it a lot in the ophthalmologist if you've ever been to one, or any simple clinic. So it's basically, this is what it looks like. This is what the Snellen's chart looks like. It has these letters from varying sizes, from the biggest to smallest. And it's just a simple test that you do. It doesn't really help you differentiate much, but because it was mentioned in your presentation, I thought I should include this. Now, how do you do this test? You ask the patient to sit at a focused distance. There's like a specific distance that the patient should sit from the Snellen's chart. Mostly it's 6 feet. But then again, there's just no like hardcore rule. And so what you do is that you ask the patient to cover one eye, okay, or you can put a patch over their eye, and you ask them to read the lines, okay? Now, normally, if you've ever had one, you would know that normally it's okay to miss one line. So let's say you can't read the last line here, which is completely fine. That is normal. Now, in patients who have bilateral vestibular impairment, they usually cannot read 5 lines, okay? So up to like here, probably here or here, if they'll stop, which is not normal. So you should think of bilateral vestibular impairment. Okay, another term that was mentioned in your presentation was oscillopsia. Now, oscillopsia it comes from the word auscultating, okay? So auscultating means something is moving back and forth rapidly. So oscillopsia is basically a visual disturbance in which we feel like a stationary object is auscultating, okay? They're not really auscultating, but you feel like it is. And when do patients mostly experience this? It's very important to ask them one question in the history, and that question should be, can you read and walk at the same time? Because that would really tell you if they have this disorder or not. Because when they're reading and walking, everything around them is moving and they feel like the words on the book or whatever they're reading, it's auscultating, okay? And if this is positive, then what do we think of? We think of vestibulo ocular reflex, okay? There is something wrong with it. There is an impairment of vestibulo ocular reflex. Okay, now, last test that someone mentioned that we do is the vestibulo spinal examination. Now we're more towards like central causes of some vestibular pathologies. First, we were testing the peripheral causes of vertigo. Now we're like towards the vestibulospinal, the central causes. Now, one very important test that you need to know is Romberg's test. So why do we do Romberg's test? It is done to differentiate between truncal ataxia and it's done to differentiate between sensory ataxia and cerebellar ataxia, okay? And it can also tell you the different causes of truncal ataxia. So it is a very important test that you do. And it's very simple. I'm pretty sure you guys must have done this in pro. So you ask patient to stand on their both feet and raise their arms, okay? And you ask them to close their eyes. Now, it is also like not a very safe test because if the patient has some problem, they may fall. So it's better if you put both your hands next to the patient and you ask them to walk with their eyes closed. Now, there was some confusion in the presentation, so I'll clarify this. If the sign is positive, it means that the patient's coordination is impaired when their eyes are closed, okay? So when their eyes are closed, they won't be able to walk with their hands out. They will sway on one side or the other. So you have to keep your hands next to them to balance them. This is a sign of sensory ataxia, okay? So Romberg test is positive in sensory ataxia. Negative sign is, okay, so in positive sign, one thing that you need to be aware of is that they can walk fine when their eyes are open, okay? Only when their eyes are closed, which is the positive sign, is when they will start swaying and falling, and this should make you think of sensory ataxia. Now, the negative sign is exactly the opposite. Their coordination is not improved when their eyes are closed. So they are unstable whether their eyes are open or whether their eyes are closed, okay? This tells you that the problem is higher up. It's in the cerebellum, all right? So is everything clear so far? Do you want me to repeat anything? Is there anything that, do you guys have any questions for me before I proceed? Okay, I need more replies. All right, perfect. Great. All right, so let's move on to nystagmus. Okay, so we already discussed what nystagmus is, so I'm not really going to go into the definition and all of that. I will start by certain disorders that cause nystagmus. So there were a bunch of things that were mentioned in your presentation. And so I have used that information that was already in your presentation. I've tried to clarify it further for you. And I've used resources from AMBOSS So I use a lot of AMBOSS stuff, and I use questions from AMBOSS so that this could help you to like get a better understanding of what is already in the presentation. So first thing that we should talk about is acute vestibular syndrome. All right, as the name suggests, it's acute. It happens very rapidly, and the patient is going to complain of dizziness. Okay, so it's acute onset of dizziness, and it's not just dizziness, it's usually accompanied by something. All right, so it could be nausea and vomiting, intolerance to head motion. So they'll say that whenever I move my head, I feel extremely dizzy. It could be gait instability and nystagmus. Okay, so acute vestibular syndrome, keep these 4 or 5 things in your mind regarding that. All right, now let's differentiate between peripheral and central nystagmus. Peripheral nystagmus is usually asymmetrical vestibular disease. So it's only on one side, all right? Not on both, it's only one side inner ear problem. And there is an imbalance of signals from the right to the left labyrinth. So they're not working, the labyrinths in the left and the right ear are not working in coordination. There's an imbalance. So how will the patient really present? They will present with jerk nystagmus, and this is what jerk nystagmus looks like. Can you see how her eyes are moving? They're literally jerking. They're moving side to side. Okay, so this is called jerk nystagmus or pendular nystagmus. And where is the origin? Its origin is in the peripheral vestibular system. So it has nothing to do with the cerebellum. It has nothing to do with the CNS itself. The problem is in the ears. And it could be both physiological and pathological. So it's not always, does not always indicate a disease. It could be physiological in some older patients. And they're often accompanied by vertigo and vomiting. All right, so 3 things that you should notice in patients: jerk nystagmus, which looks like this, nausea, vomiting, and vertigo. All right, now what are the causes that you will see in which you will see peripheral nystagmus in? Migraine, BPV, Meniere's disease, and labyrinthitis. So all of these things, we will talk about it later in the presentation, but I just wanted to get this out of the way, and then we'll jump into the different diseases. Okay, now central nystagmus. Just like the word suggests, there is something wrong with the problem is with the central nervous system. Okay, so the nystagmus is either vertical, which means it moves up and down, the eyes move up and down, or it's horizontal, which means they move side to side. Okay, now what will you observe? You will see jerk nystagmus, same as this. It looks exactly like this. And it's originated in the central nervous system. Again, it does not always indicate a pathology. It could be normal as well. And when you try to ask the patient to fix their gaze at something, they won't be able to fix it, okay? This, usually when you see central nystagmus, think of central causes. What could be central causes? Problems with the brain. So number 1, it could be a stroke, right? It could be Wernicke encephalopathy. It could be multiple sclerosis, or alcohol intoxication or drug intoxication. Anything that affects the body centrally, that affects the central nervous system, can cause central nystagmus. So one of the safest answers when you're doing the exam and when they ask you, what are the signs that you would see in stroke? Okay, let's say you get a question like that, signs of stroke. One of the simplest answers and easiest answers you can say is nystagmus. All right, because nystagmus is usually present in most of the central problems with the CNS. All right, now any questions regarding nystagmus? Is there anything you want me to repeat? Is everything clear, you guys? Okay, so I'm going to assume everything is clear, and I'm going to move on to vertigo. All right, so let's differentiate between the peripheral and the central causes. Okay, so with peripheral, it's mostly, okay, so what is the main difference between peripheral and central? It's the etiology. What causes it? Because if you see anyway, and maybe it's the type of nystagmus as well, the way the patient's eyes are moving, Here in central nystagmus, you will see them moving up and down or horizontal, but in peripheral nystagmus, you will see it into mostly a jerk nystagmus. You will see that most commonly, which looks like this. And then it's the causes. That's what really differentiates between central and peripheral. Okay, now let's differentiate between peripheral and central vertigo. So first thing that is very important, and I think that's the main distinguishing factor between the two, is the onset. So with peripheral cause, it appears all of a sudden. Okay, patient sitting, they're immediately going to start feeling dizzy. With central, it's usually gradual. It doesn't happen rapidly. And with peripheral cause, you can hear tinnitus, or there's some sort of hearing deficit involved. Whereas with central causes, because it's not arising from the inner ear, it's usually coming from the cerebellum or the brain, you don't really have any auditory symptoms. The patient is not really going to exhibit any auditory symptoms, all right? Again, nystagmus can be present in both, but another differentiating factor between the two is that nausea and vomiting can be seen in peripheral, but not in central, okay? So I hope that you can use this to clearly differentiate between the two. Okay, now peripheral nystagmus. So peripheral vertigo. So it's caused by dysfunction in the inner ear. So the vestibulocochlear nerves or the semilunar canals. There is usually some problem with them. It could be a lesion, it could be a dysfunction, it could be a tumor, and that is what causes the vertigo, the dizziness. Now, what are the causes of peripheral vertigo? You can have benign paroxysmal positional vertigo, BPPV, and it occurs because there's something stuck, there's debris stuck in the semilunar canals, and we'll talk about this in a little bit. You could have vestibular neuritis or labyrinthitis. Meniere's disease, again, we'll talk about this, and herpes zoster urticus. So you might have heard of this as Ramsay-Hunt syndrome. So that's another word for herpes zoster urticus. Okay, central nervous system is caused by inner ear like cerebellum or brain or vestibular nuclei dysfunction or lesions, all right? So it could be stroke, it could be an ischemic stroke, a hemorrhagic stroke, you could have tumors like schwannoma, meningioma, or it could be because of migraine or demyelination disorders like MS. Okay, so let's first talk about benign paroxysmal positional vertigo. Now, this is very commonly asked in the exams, and I would highly suggest that you pay attention in this part, okay? So it's one of the most common causes of peripheral vestibular vertigo. And so what really happens here? Usually there's some semicircular canal dysfunction. It could be a stone that gets stuck in the semicircular canal. It's called canalithiasis. So just like urolithiasis, if you guys heard of it, lithiasis means stone. So any debris, when it accumulates, it forms stones, and that could be lodged into the semicircular canals. And then when the patient moves their head, they can become loose and they can fall into the posterior semicircular canal, causing the sensation of dizziness, basically. All right. It could be endolymphatic debris. So another name for canalithiasis is endolymphatic debris. We know that there is something called the endolymph in the inner ear, right? So when that accumulates, it can form, and it can harden, it can form the stones. And when the stone dislodges, it causes this abnormal stimulation of the vestibulocochlear nerve. So when that is continuously stimulated, it causes, in response to head change, it causes the sense of dizziness, all right? And how does it present? It presents with severe attacks of dizziness, which can last several seconds, all right? Now, a very important keyword to look into the question when they're giving you symptoms, I highly suggest look at signs of episodic dizziness. Okay, the patient will say, I was picking up something and I was bending over and picking up something, or I was laying down and coming to supine position and I had this sense of dizziness. That is very indicative of BPPV, all right? And it usually comes very suddenly, and the episode of dizziness lasts less than a minute. So it's very rapid, all right? And it's caused by certain head movements, abrupt head movements, and it can also be associated with nystagmus. So 3 things I want you to be very, very, very vigilant of in the questions: episodic vertigo, nystagmus, and the patient will say that each episode of dizziness lasts about a minute or less than a minute, okay? It does not usually cause any neurological symptoms, no tinnitus, no hearing loss. And yeah, so the triggers, like I already mentioned, it's like quick rotation, quick movement of the head, okay? Now, Meniere's disease, again, very important. You may find some questions on this. So Meniere's disease, how does it happen? How does it occur? It's basically due to impairment in the absorption of endolymph. So we know that endolymph is absorbed. It's a fluid that's circulating in our inner ear, and it's responsible for this balance. That when it moves, when our head moves, the endolymph moves, and it gives us the sensation of movement, right? So when there's impairment in absorption, it forms endolymph hydrops, okay? It just accumulates in the endolymphatic sac. And that is the main pathophysiology of Meniere's disease. So endolymph is very rich in potassium, and perilymph is very rich in sodium. So this, you probably have taken this, but I will reemphasize this again, that endolymph is very rich in potassium, and perilymph is very rich in sodium. So the concentration of potassium in perilymph increases because the endolymph is accumulating, all right? So there's this exchange that's happening. So diagnostic feature of this is that perilymph potassium concentration would be high. And if you take, you do histological examination, which is not indicated always, you will see that the entire endolymphatic system would be engorged. It would be distended, okay? All right, so very important thing in clinical presentation that you must remember, we talked about the 3 things that you need to know for a BPPV. Very important thing for Meniere's disease is I want you to know the triad, okay? The triad says that there would be peripheral vertigo, tinnitus, and asymmetrical sensorineural hearing loss, all right? So 3 very important things, look for it in the exam question: peripheral vertigo, tinnitus, and asymmetric sensorineural hearing loss, okay? And again, it's episodic episodes of acute unilateral symptoms. Now, here's the thing. In Meniere's disease, it lasts from minutes to hours, whereas with BPPV, we said that it lasts less than a minute. The patient is going to complain of recurrent episodes of dizziness, but they'll say that each episode lasts about less than a minute. It's very short, it's very brief. Whereas in Meniere's disease, patients are going to say it lasts an hour or it lasts 20 minutes or something like that, okay? Now, what are the diagnoses? that you should focus on. So one thing that I noticed is in your presentation, the doctor didn't focus on management or diagnosis, whereas if you open Ambos, it comes with the entire package. They talk about the management, the treatment, the diagnosis. So I would suggest that you stick to what is inside your presentation, because that is what you're going to have the questions on. And if they bring any questions from outside the presentation, that you have, you know, proof and evidence that this is what was taught to us, basically. I would not recommend going into details about every disease, but diagnosis of Meniere's disease was discussed in your presentation, so I'll quickly go over it. You do subjective audiometry in Meniere's disease, and it should be performed in both the ears, okay? And what would the audiogram show? It would show a low frequency sensory neural hearing loss that increases during these attacks, all right? So the sensory neural hearing loss is always there, but it's going to like increase when there's an attack of dizziness. All right, so before we move on to the simpler diseases, do you have any question regarding Meniere's and BPPV? Clear, okay. Anyone else? Do you have any other questions for me? Do you want me to repeat anything? Do you want me to go over anything? Okay, perfect. All right, so let's proceed to some. Are there tests for them? For what? Tests for what? Someone's asking if there are tests, but tests for what? Yeah, so the test that you can do an audiogram for Meniere's. I'm not going to really tell you about BPPV because, again, like I said, the diagnosis is not your focus. One of the only things that was mentioned in your presentation regarding diagnosis was Meniere's disease, that you have to do an audiogram, and that would show you sensory neural hearing loss. So that's all that you need to know, and that's all that I have focused on in my presentation as well. All right. So let's move to multiple sclerosis. Okay, so multiple sclerosis, as we know, is a demyelinating disorder. All right, so around the nerve cells, around our nerves and neurons, we have a layer of fat that insulates these neurons, and that layer of fat is called myelin sheath. Okay, so demyelinating disorders comes from the term myelin sheath, in which this insulation, this pad of fat around the nerve fibers, it starts to disappear because of an autoimmune reaction in the body. And so that affects everywhere in the body, because these nerves, they're present all over the body. So it's not, multiple sclerosis does not specifically affect one part of the body. Instead, it affects all over. So it presents with a range of symptoms, from vertigo to nystagmus to headaches, loss of bowel function, loss of bladder function. But we are discussing multiple sclerosis in the terms of dizziness or vertigo. So initial symptom, vertigo is the initial symptom in about 5% of MS patients. So 5% of MS patients that walk into the clinic, their main first complaint is dizziness. They'll be like, I'm experiencing severe episodes of dizziness, okay? But the number is very few, it's only 5%. But in 50% of MS patients, vertigo may present anywhere along the course of the disease. So it could be a late presentation, it may not be an immediate presentation all the time. Now, what are the common signs and symptoms of multiple sclerosis that causes vertigo is internuclear ophthalmoplegia. You can have optic neuritis, you can have vibratory loss and spasticity. Their muscles become very spastic, very rigid, okay? And what do you do to diagnose multiple sclerosis? The gold standard test is MRI with FLAIR, and you use T2 MRI, okay, to reveal these hyperintense spots, because when the nerves are demyelinating, they're going to appear bright. It's a very classical picture on MRI, and you cannot miss it. You cannot miss MS on MRIs, okay? So again, one of the things, MS is a very popular topic. So I would highly suggest that you go over MS very, very, very well. Okay. All right, now let's talk about migraine-associated vertigo. So if dizziness is associated with migraines, you would usually see a catamenial component, which means that this word was used in your presentation. So I really want to focus on what this term exactly means. It means that it's relating to the menstrual cycle of the female. It's relating to the menses. So every time the female is going to have menses, she's going to experience episodes of dizziness. And these episodes of dizziness, they usually get worse by oral contraceptive pills, OCP usage. A very important question to ask in history would be, when you were a child, did you experience recurrent episodes of abdominal pain or vomiting? Because that is equivalent of migraine, but in children. Okay, very, very important thing to ask in history is, when you were a child, did you experience recurrent abdominal pains and cyclical vomiting? Okay. All right, now let's talk about vestibular neuritis. So this term, you must have heard of it a lot. And what does it exactly mean? Now, the term neuritis means inflammation. Itis always means there is an inflammation going on. So vestibular neuritis means there is inflammation of the vestibular nerve, okay? So if there is inflammation of the vestibular nerves, there's some irritation going on. What would this present as? It would present as severe dizziness. The patient is going to complain of massive episodes of dizziness, nausea and vomiting. They will complain of instability, gait instability. And usually what should, click in your head is that the patient will fall towards the side of the lesion, okay? And nystagmus. So very typical features. Again, these are all features that would commonly be seen in other presentations. Like, these are common presentations. They can be seen in other dysfunctions and disorders. But all the functions of the vestibular nerve would be impaired. So it would lead to these clinical features. So the dizziness, it lasts for a few days, and it increases and decreases. It crescendos in a few hours. And so it increases in a few hours, and then it's going to decrease in severity. So it's like a wave-like pattern. All right. So another tumor that we should discuss is schwannoma. So schwannoma is basically a benign tumor, and it's very commonly seen in children. It's most commonly seen in children, not so common in adults. And it's a benign Schwann cell tumor. So like I just said, myelin sheath is this pad of fat that protects the nerve fibers. Now, what really produces this layer of fat? It's the Schwann cells. All right. So Schwann cells, when they undergo hyperplasia and dysplasia, they can form a schwannoma, a tumor, and this involves any peripheral nerve. Now, if you go back to like the basic physiology, you would know that Schwann cells are not present in the central nervous system. They're usually present in the peripheral nervous system. So it only involves any one peripheral nerve. But if there is bilateral involvement, always think of neurofibromatosis type 2, okay? Type 2 neurofibromatosis is very important to remember when you're talking about schwannoma. So schwannoma is most commonly unilateral. If it's bilateral, I want you to think of neurofibromatosis type 2, okay? The gene that I want you to remember for schwannoma is neurofibromin 2 gene, or NF2 gene, okay? So but there are a lot of 2s, okay? If it's 2 schwannomas, think of neurofibromatosis type 2, gene mutation, NF2 gene, okay? And this is a loss of function mutation. And yeah, so in this image, you can see that the schwannoma is again unilateral. It's here. This is the tumor, and this is the vestibular nerve, if you can see, with the tumor here. Okay. Before we move on to before we further move on to the clinical symptoms of schwannoma, is there anything that you want me to repeat or discuss? Is everything clear, you guys? Okay, can I repeat the point about twos? All right, sure. So I want you to remember the twos for schwannomas. Schwannoma, if it's bilateral, so if there are two tumors on either side, I want you to think of neurofibromatosis type 2. So that's the second two. And the gene involved is the loss of function mutation in neurofibromin or NF2 gene. All right, clear? Should we move on? All clear. Okay, everyone is good. No questions so far? Okay, perfect. All right, so let's move on to the signs and symptoms. So schwannoma can happen in any peripheral nerve, and it does not really require, yes, they are in PNS, the peripheral nervous system. Okay, so no, this isn't the peripheral nervous system. Let me show you here. This is the ear, so this is the brain. You're looking at it from the top. You are looking at the inner ear over here, and it's in the peripheral nervous system. This is in the peripheral nerve. The vestibular nerve, when it leaves the CNS, comes out of the skull, leaves the brain, and then when it's supplying your inner ear, that's where you're going to see this. All right, okay, so let's talk about schwannoma and the presentation of schwannoma. So basically, there are two presentations, and all of these are discussed in your presentation, the one that Dr. Alkawi gave, but I just organized it so you can understand it better. Schwannoma can present anywhere in the body, any peripheral nerve in the body, and it presents in two ways. There's some early symptoms, and then there are late symptoms, okay? Early symptoms are due to the expansion of the tumor itself in the internal acoustic canal, okay? And because of that, it causes pressure on the vestibulocochlear nerve, which is cranial nerve number 8. All right. So when it causes compression, it gives symptoms related to these nerves. All right. Again, these are early symptoms. So earlier on in the course of the disease, you will see symptoms related to cochlear nerve and vestibular nerve. So when cochlear nerve is damaged, what does the cochlear nerve supply? It supplies your cochlea, right? So you will have hearing deficits. So sensorineural hearing loss, tinnitus, again, usually unilateral on the side that it's affected, not bilateral. If it's bilateral, think of neurofibromatosis type 2. Now, in case it compresses the vestibular nerve, vestibular nerve is responsible, it supplies your vestibule, which is responsible for your balance, right? So what will you see? You will see signs of dizziness, or you will see signs of imbalance in the patient, all right? Oops, just a second, right. So the patient would have dizziness and ataxia, gait abnormalities if the vestibular nerve is compressed due to the expansion of the tumor. So usually the patient is going to fall on the side of the lesion. Let's say it's in the right side. So the person, you will see when they're walking, they will have gait ataxia and they will fall on the right side. All right. Now, later on in the disease, the tumor is now going to compress the structures around the vestibulocochlear nerve. So first it was compressing the vestibulocochlear nerve. Now it's going to compress the structures around it. Now, what are the nerves that run by vestibulocochlear nerve? You have the trigeminal nerve and the facial nerve. Okay, so if the trigeminal nerve is affected, you know that the trigeminal nerve supplies the entire face. So you will have facial paresthesia, you will have hyposthesia, and you will have unilateral face pain. Again, unilateral towards the side of the lesion. If the facial nerve is being compressed, then you will have unilateral facial paresis, xerophthalmia, and xerostomia. Okay, so that means drooping of the eyelid and deviation of the eye. All right, so I hope that that's clear. Let's move on to the Wallenberg syndrome. Now, Wallenberg syndrome is basically another name given to stroke. So once stroke occurs, the symptoms that accompany that stroke is called the Wallenberg syndrome. All right. So the Wallenberg syndrome occurs when there is ischemic occlusion of two very important arteries that you must remember the names for, and that's why they're bolded and into a different color. It's called the posterior inferior cerebellar artery, or pica, and vertebral artery. So ischemic occlusion or arteriosclerosis of posterior inferior cerebellar artery and vertebral artery can lead to Wallenberg syndrome. Now, what are the clinical features? I will discuss the clinical features of ipsilateral stroke. That means it occurs in one pica and vertebral artery. I'm not going to talk about if it occurs on both, because the symptoms are more severe, and to be honest, they were not discussed in your presentation. Now, again, the symptoms differ according to the location, and that is the beauty of the whole, neural block, is that once you know what part of the brain is responsible for what function, you can easily guess the symptoms that would arise in case of a stroke or a hemorrhagic shock or tumor. You can easily guess, because if you know the function, then you can easily guess the pathology related to it, okay? So symptoms of Wallenberg syndrome, let's say that the ischemic occlusion occurs near the nucleus ambiguus. Now we know that nucleus ambiguus is your motor area, right? This is the motor nuclei. So here, it occurs if the ischemic stroke occurs near the nucleus ambiguus, and if that's what's affected, then you have dysphagia, motor function, again, motor function, gag reflex, weak gag reflex, hoarseness of the voice, and dysphonia. Okay, so think of all the motor functions, and that would be found deficit in Wallenberg syndrome. Now let's say that the inferior cerebellar peduncle is affected. Now, this area is responsible for your balance, right? Cerebellum, responsible for your balance. So what would you see in the patient? You will see ataxia, you would see dysmetria, you will see dysdiadochokinesia. Let's say the sympathetic fibers are affected. What will you see? Something very popular, always whenever you think of sympathetic fiber dysfunction, problems related to the sympathetic fiber, even if you don't know what it is, you don't know the nature of the disease, you see sympathetic fibers are affected, always first answer immediately Horner syndrome. Okay, and uncontrolled hiccups. But Horner syndrome is most of the time always related to the sympathetic fibers. All right, so, oops, my bad. All right, if the vestibular nuclei is affected, then think of vertigo, vomiting, nystagmus. Okay, so Wallenberg syndrome, one last thing that I would like to mention about it is you may find it in the books or on AMBOSS or in the exam with another name. It's also called the lateral medullary syndrome, and this name I think was mentioned in your presentation. And yeah, okay. So this is what the lateral medullary stroke looks like. What you're looking at here is the MRI, and that's why the stroke right over here, it's in the cerebellar peduncle, and it's this white lesion that you see. I'm sorry, I couldn't find a better picture. This is the best I could find you. And yeah. All right, so we are almost towards the end of the presentation. Yeah, we're almost towards the end of the presentation. Let's quickly finish, and then we'll solve some AMBOSS questions that I have for you. Okay, so far we talked about dizziness that usually have a problem in either the ear, the inner ear, or the cerebellum. Now we're going to talk about causes of dizziness that are not related to the ear and that are not related to the cerebellum. So the most important cause, once you've ruled out any CNS related or inner ear related cause, the most important thing that I want you to know is blood pressure problems. So blood pressure problems, almost every, every other person that walks in your clinic would have some blood pressure related issues. Okay, so whenever they come complaining of dizziness, never forget to check their blood pressure. One of the very important things that I want to talk about here is vasovagal syncope. Now, vasovagal syncope is this transient drop in blood pressure, which causes syncope, an attack of syncope. The patient loses their consciousness and they fall. Why is that? It's because the blood vessels in your body vasoconstrict. The sympathetics, there's a massive sympathetic stimulation. The blood vessels in your body constrict and there's pooling of blood. And this causes decreased blood supply to your brain. Understood? And because of that, the person faints, they drop. This is like 29% of patients with vasovagal syncope would have some sort of problem. And usually you would see this in younger patients. So these patients would complain of dizziness and fainting after a trigger. So they go to donate their blood and they're going to faint. Okay, that's vasovagal syncope. They will hear like very bad news, emotional stress, and they will drop, they will faint. Again, all causes of vasovagal syncope. Okay, now let's talk about orthostatic hypotension. Now, you probably would have heard of this a lot. It's the same mechanism as vasovagal syncope, but here it's a little different. This occurs not because of excessive sympathetic stimulation. This occurs because there is pooling of the blood in your extremities. So you're sitting and the blood is pooling in your extremities, in your lower limbs, right? But then when you stand up, there is decreased supply to your brain and then the person faints, okay? So 5 to 29% of all dizziness and syncope are related to orthostatic hypotension. This is most commonly found in older patients as opposed to vasovagal syncope. And the most common underlying causes are hypovolemia, they haven't eaten much, or they're taking some medications that cause vasodilation, or they have been on the bed for a very long time. They've been sitting or laying down for a very long time. So when they stand up, they use the term head rush. So this is what it is, okay? A very nice mnemonic that was in your presentation is PASS. So pressure, arrhythmia, seizure, and sugar. Okay, so low sugar, low blood pressure, arrhythmias, any problem with the heart, and seizures, all causes of orthostatic hypotension. So what are the investigations you would order? Now, there were several investigations mentioned in your presentation. So I've organized them into a few categories. So number one thing is that when a patient comes complaining of syncope, you measure their blood pressure, okay? It's very important to measure the blood pressure in 3 positions or in 3 states. 5 minutes after they're in the supine position, so you ask them to lay down and then you measure their blood pressure. And then you ask them to stand up, you wait for a minute, you measure their blood pressure. You wait for another 3 minutes, you measure their blood pressure. Okay, so these 3 things, remember them. Observe if there are any signs of hyperventilation after 3 minutes of standing up. Obviously, you order their CBC, check their electrolytes, measure their glucose, check for any electrolyte imbalance, low sodium, high potassium, could like guide you towards arrhythmias. And another thing that you do with these patients is you attach them to a Halter monitor. So if you see in this picture, this is what a Halter monitor looks like. And it's basically used to measure, it's like an ECG device that the patient is on for 24 hours. So it checks the heart for any arrhythmias for 24 hours. There are 12 electrodes that are attached to the patient. You can send the patient home with them, and then you can ask them to come the next morning with this device, and you can check if they have any arrhythmias overnight, if their if their electrical activity in the heart was completely fine. All right. So yeah, this is the third thing that your professor talked about in terms of investigations. Okay, so last thing that we're going to talk about is imbalance. Let me just make sure this is the last thing. Yeah, this one's the last thing. And then we'll move on to some questions. So ataxia. Now, ataxia, it's a general term that is used for a group of disorders that affect coordination, balance, and speech. All right. So usually, if ataxia occurs abruptly, if there is an acute onset, meaning that it occurs from minutes to hours, this is a medical emergency. You will always, always, always immediately book the patient. You will do their EEG. You will check for any signs of stroke, any signs of ischemia, because again, ataxia along with vertigo, syncope, nystagmus, all signs of stroke, all signs of hemorrhagic or ischemic strokes. Okay. So what are the causes of common acute ataxia? Think of toxins, think of any medications they may be on, think of ischemic or hemorrhagic stroke, all right? Again, there are two types of ataxia, motor and sensory ataxia. All right, so before we jump on to the different types of ataxia and the causes, I want to discuss and take you a little bit back to the cerebellum and talk a little bit about the cerebellum. So for the sake of this lecture and this presentation, there are two types, two types of cerebellum areas, the functional zones of cerebellum that you should really focus on. The vestibulo cerebellum and the spinal cerebellum, okay? So because these two are related to your balance, they're related to the gait. So the vestibulo cerebellum, it has the vestibular nuclei of cranial nerve 8, okay? And it coordinates with your muscles, like your hand and legs muscles, and it coordinates with, axial muscles. That means muscles that are present in the axial skeletal system. So your face, your eyes, your ears, your all the axis, the main axis of your body, they coordinate with those muscles. So they position your eyes, your neck, your trunk, okay? They're responsible for the positioning of your eyes, your head, and your trunk. They're responsible for balance and any ocular movements, gait stability, and the vestibulo cerebellum is also responsible for your gaze as well. Okay, if there are any lesions or if there's any damage to this area, it can cause vertigo and nystagmus. All right, so we said that normal function of vestibulo cerebellum is balance and ocular movement and gait stability. So obviously, if there was impairment in any of these, what would it lead to? It would lead to vertigo and nystagmus. All right, now let's talk about spinocerebellum. So spinocerebellum, it receives input from your trunk and your proximal portions of the limb, so your fingers and your toes and your trunk. These fibers, they go to the spinocerebellum, from the spinal cord to the cerebellum, and that's why it's called spinocerebellum, and they coordinate the movement of your limbs. Okay, so remember what dysdiadochokinesia is, where you touch the patient's, where you touch the doctor's finger and you put the tip on your nose. So this thing is responsible, the spinocerebellum tracts are responsible for the dysdiadochokinesia. And so it's responsible for your muscular tone, it's responsible for your limb movement, your body movement, and any problems or any lesions in the spinocerebellum can cause truncal and gait ataxia. Understood? I hope that's clear. All right, so last two things that I want to mention are cerebellar infarction and cerebellar hemorrhage. So cerebellum infarction is basically a lack of blood supply or stroke in the cerebellum. And what would it cause? Think of all the functions of the cerebellum, and any deficit in that is what the cerebellar infarction would cause. So ataxia, nystagmus, slurred speech, gait abnormalities, all of that, okay? If the cerebellum hemisphere is affected, so think of ipsilateral limb ataxia, intentional tremor, that's why they have dysdiadochokinesia. If the vermis is affected, think of truncal ataxia, nystagmus. Other signs that they may have is facial weakness, gaze palsy, headache, vomiting, neck stiffness, and a very classical gait that these patients would have is drunken sailor gait. So they have ataxia, and you will see them stumbling like a drunk sailor. Okay, cerebellar hemorrhage. So if you can see, this is the ischemia. Both of these are CT scans, and you can see that this dark patch is the ischemic patch. All right, ischemia always appears dark on the CT scan, whereas a hemorrhage always appears bright on the CT scan. Okay. All right, so in case of hemorrhage, the patients would have acute onset of vertigo, nausea, vomiting, headache, inability to stand, nystagmus, dysmetria, truncal ataxia, and so they would require prompt evaluation, medical admission. You would need to do surgery on them. Otherwise, because of the increase in pressure, their cerebellum can herniate, and they can go into coma or death. Okay, so that brings us to the end of the lecture. Now we're going to move on to some AMBOSS questions. Before we move on, do you have any questions for me? Is there anything that I should answer or repeat? Please let me know. Is everything clear, you guys? Okay, more responses. I only see one person. All right, perfect. Okay, now let's move on to the questions. I want someone to read this. Or how about I read this and don't answer until I tell you to answer, okay? So don't answer yet. So there's a 57-year-old woman who's brought to the ER because of a 6-hour history of persistent vertigo and nausea. So she was unable to walk due to dizziness. She has hypertension. There's no history of trauma. She has high cholesterol. She smoked. And she drinks 2 glasses of wine on weekends. So far you have like a significant history. She's on these medications. She's uncomfortable. She's alert. She's oriented. Her vitals are fine, actually. Her blood pressure is slightly elevated. And so now you do a neurological exam, which shows normal strength and sensation in all her extremities, so her sensory function is fine. She has reflexes that are 2+ throughout, and she sways towards the right side when she stands upright with her feet together. So this is a positive Romberg sign. She's able to fix her eyes on a stable point when her head is rotated. So remember, we talked about the horizontal rotation of the head, so that is fine. But she has vertical nystagmus that persists on gaze fixation of the right eye. So the otoscopic examination showed that her tympanum is normal bilaterally, and she's able to hear her fingers rubbing next to her ears and repeat the words that are whispered to her ear bilaterally. So her hearing is fine. So what is the most appropriate next step that you would do for this patient? Any answers? It's okay. I mean, if you guys don't know the answer, you can just say it and we'll discuss it. It's fine. It's okay to make mistakes. Okay, any more answers? I have 4 people replying to me so far. Excellent. Yeah, exactly. So the answer is clearly MRI. Audiometry is not the most important thing here because you can clearly tell that her hearing is completely fine. She does not have any, sensorineural hearing loss. Caloric testing not indicated, lumbar puncture not indicated in this patient, and you cannot do a lumbar puncture until you confirm that her MRI is normal, because in case of any cerebellar herniation, if you do a lumbar puncture, you're going to herniate the cerebellum further. You can cause more damage. Okay. All right. This question. there's a 47, again, don't answer till I'm done reading, okay? So there's a 47-year-old woman who comes to the physician because she has a 3-month history of recurrent episodic nausea, and she feels like the room is spinning, so vertigo, okay? And each episode, she says, lasts less than a minute, and she says that it usually occurs when she gets out of bed in the morning or when she suddenly turns her head. She's not vomited, and she does not have any headaches. She's asymptomatic between these episodes. Which of the following findings most closely correlates to the patient's symptom? All right, so what are your answer, guys? Okay, any more answers? Okay, so Tariq, do you mind unmuting and explaining why you picked me? Okay, I guess he does not want to unmute. All right, it's fine. It's completely okay. I'll explain. Okay, so here are the keywords that you need to focus. Number one, okay, so the answer, by the way, is B, it's nystagmus. Now, here are the keywords that you need to focus on. Number one, each episode lasts less than a minute. Again, that should trigger you. As soon as they say that, that should trigger you, and that should keep the thought in your head that this may be BPPV, benign paroxysmal positional syncope. Think of what else did she say? Oh yeah, when she gets out of bed, it gets worse. So again, abrupt head movement causes this. She does not have any vomiting. She does not have any hearing loss. She does not have any headaches. She's asymptomatic between these episodes. So this is most probably nystagmus. In fact, this is nystagmus. Positive Romberg sign would not be seen in BPPV. Again, orthostatic hypotension is not seen in BPPV. Nystagmus is the most common sign that is seen. Okay. Is it clear? Is what I just explained, is it clear? Do you want me to explain anything here? Clear? Okay. All right, perfect. So again, one more time, I'm going to go over the important things, the catchphrases. Less than a minute, gets out of it happens when she moves her head suddenly and when she gets out of bed, and it's episodic, okay? And she's asymptomatic between the episodes. All right, okay. Now, third question, this is our second last question. There is a 51-year-old man who comes to the physician because of recurrent episodes of dizziness, tinnitus, hearing loss, okay? On the left side of this for 6 weeks. These episodes, they last for hours at a time and are associated with sensation that the room is spinning. He has no history of major medical illnesses. He takes no medication. The examination shows horizontal nystagmus to the left. The Weber test shows lateralization to the right ear. Rennie test is positive bilaterally. Which of the following is the most likely cause in this patient? So demyelination, acoustic neuroma, endolymphatic hydrops, or pica infarction. All right. Excellent. Very good. It is C. Here they're talking about the Meniere's disease, the classical triad of Meniere's disease that I asked you to remember: tinnitus, dizziness, hearing loss. Okay. Another thing that would hint towards Meniere's disease is the fact that this patient experiences it for hours at a time. Okay, minutes to hours. That's another classical sign of Meniere's disease. Demyelination, that would be seen in MS. Acoustic neuroma, again, not here, that's most likely schwannoma. Pica infarction would have more global effects like ataxia, gait abnormalities, other things, okay? All right, last question. So a 79-year-old woman is brought to the emergency department because of 1 hour of hoarseness. Her pulse is 85, her blood pressure is 142/90, which means it's raised. Physical examination shows diminished gag reflex, loss of pain and temperature over left side of the face, right trunk, and extremities. There is no facial asymmetry. the tongue does not deviate when protruded. Her strength is 5 by 5 bilaterally, and her ophthalmological examination shows involuntary rhythmic ocular movements, which is a sign of nystagmus. She has left-sided meiosis and ptosis, and the patient's condition is most likely caused by which of the following occlusion in the vessels. So is it posterior cerebral? Is it anterior inferior, posterior communicating, or posterior inferior? Excellent. This is pica. This is Wallenberg syndrome. Again, know the signs of Wallenberg syndrome. And again, these are the kind of questions that might come in your exam. Thank you so much, you guys.